Okay, well, it is 9:45. I want to thank everybody for joining this morning. You are in breakout session number 4, and we're going to go ahead and get started. My name is Lisa Noguchi. I'm Director for Maternal Newborn Health at Chicago, and I'm very pleased to introduce our speakers for this morning. Beth Yeager, the Deputy Director of USAID's Promoting the Quality of Medicines Plus program led by USP, and Afua Nkumaagre, who is currently the Family Planning, Reproductive Health, and MNCH Program Officer for USAID's Global Health Supply Chain Program, Procurement and Supply Management Project in Ghana, where she's been providing support to family planning, commodity procurement, and MNCH technical activities. And Beth, I think you might like to introduce a couple of the speakers on your team.
Yes, thank you. Also with us this morning is Ms. Claudette Aliba Diogo, and she is the National Family Planning and Logistics Program Officer who is responsible for reproductive health commodities with the Ghana Health Service. She has over 10 years of experience working there. She is a pharmacist by profession with a master's in science and international healthcare management and economics, and has been working very closely with EFWA on the work that EFWA and she will be presenting. Also with us is Megan Rauscher, who is the Deputy Technical Director of the Maternal and Child Health Task Order of the Global Health Supply Chain Procurement and Supply Management Program, also a USAID program. And I will just say a few words and then we'll get into the meat of this presentation. But one of the major challenges we face in providing quality care and saving lives is, of course, ensuring availability of quality assured medicines and medical products. In pre-COVID days, this was already a challenge. These products, as we all know, are not heavily supported by donors like products for malaria or tuberculosis or HIV/AIDS are, which means that central and local level governments are largely responsible for procurement and funding procurement of these products. Another issue that affects the quality of products that are available in given markets are weak national medicines regulatory authorities who are struggling in many cases to ensure the quality of products in circulation. And then of course there are weak supply chain challenges as well, or supply chain challenges in many contexts that affect availability and also quality of products. In the current context, of course, all of this is exacerbated. Global supply chains are disrupted. So even when local manufacturers exist, the primary ingredients, the active principal ingredients, are often not available locally. Also, resources are, of course, being diverted to emergency supplies for the pandemic. So all of this to say, we have our work cut out for us in ensuring availability of quality assured supplies for maternal health. Today, we're going to talk about a very specific challenge that we have been talking about for a long time, maintaining the quality of oxytocin. Oxytocin, as we all know, remains an essential element in our toolkit in preventing maternal mortality. And today we will discuss how Ghana has been working to address that challenge with some very specific examples and actions. So over to you, Efwa.
Thank you, Beth. So today we're going to discuss how Ghana streamlined our oxytocin supply chain to ensure that we had high quality oxytocin, which of course affects maternal health outcomes when it comes to maternal mortality. We're going to look at the steps that we took to improve the quality of oxytocin in Ghana. We're going to check the entire supply chain as we did the work, procurement and sourcing practices, regulatory environment, our reimbursement schemes, finance schemes, our inventory management and logistics with a focus on supply chain. Generally, maternal health in Ghana has improved over the decades, I would say, but suffice me to say that it has improved at a snail's pace, at a very slow rate. Currently, as per our maternal health survey in 2017, we realized that our MMR rate is about 310 per 100,000 lives births, with PPH, postpartum hemorrhage, being our lead cause of deaths when it comes to in mothers. So we thought about it as a team and as a project, and we realized that there's something that we need to do about it, because we know that one of the commodities which WHO recommends as a life-saving commodity for postpartum hemorrhage was oxytocin. So we decided to look at our oxytocin supply chain and look at what we could do to ensure that the oxytocin in country was quality and help to flatten the maternal mortality curve. We realized that oxytocin was a problem. One market survey that the Ghana FDA had conducted showed a high failure of rate of oxytocin when it comes to assay rates. There was about 56% and 62% in a 2013 and 2014 survey respectively. So we realized that indeed there was an issue with the oxytocin supply chain, and as a country we needed to do something about it. When it comes to oxytocin quality of oxytocin could be threatened at any point in time in the chain, as shown by this curve. It could be threatened right from the manufacturing stage to the point of usage when it is used on the client. Oxytocin quality could easily be affected. At the point of manufacture, if the quality of the active ingredient, the API in the oxytocin is of low quality, then we know that it's a non-starter right from the beginning, because whatever the oxytocin that will come in country will definitely be of low grade. Any point in time in the chain, oxytocin could be exposed to heat. There could be temperature excursions in the oxytocin supply chain, which could affect the quality of the product, and therefore it could degrade as it goes along the chain, right from the wholesalers to the point to the pharmacy, to the point where it is used on the client. Oxytocin quality could easily be affected at any point in time in the chain. So what we as a team did was that we studied the supply chain holistically, right from how it is managed currently, to be able to propose recommendations to how the supply chain should be managed to achieve the quality intention that we had set off to achieve in the first place. So we realized that oxytocin in country was formerly being procured by UNFPA. UNFPA had procured oxytocin for the country in 2017. And since it was donor procured, it was centralized and moving from the central level to the RMS and subsequently to their facilities. So one unique thing was that it was supplied at a subsidized rate. So the oxytocin was not, the price of oxytocin which you found in the RMS didn't match the price on the ground, the international prices, since it was being supplied at a subsidized rate. So therefore, what the RMS and the facilities were doing was that they were also issuing individual contracts to the various manufacturers and various suppliers, and they were getting oxytocin from there. So then the resellers would deliver directly to health facilities if the RMS was stocked out. If the health facilities requested for oxytocin from the RMS and could not get, they went ahead to source these products from the different manufacturers that were on the open market. They also studied the volumes at the facility level versus the volumes at the RMS level, and also studied the beds. We picked data from the DIMS to also study the beds in country. And we realized that as the diagram you can see from the diagram, there is the needed volume and there's the actual volume. We realized that the needed volume did not match the actual volume. If you studied the beds that happened in country and you studied the volumes of oxytocin that had moved out of the RMS, they did not match. There was always a disconnect. One assumption we made, though, which I should state, is that we assumed that 1 ampoule of oxytocin was used per beds. And therefore, 9% of PPH case rate meant that 4 ampoules of oxytocin were used. We did not include induction or augmentation in this. So we realized that there was a disconnect, meaning that the facilities were getting their oxytocin from different sources other than the RMS, sources which we could not quality assure. So then, as a country and as a team, we had to do something about our oxytocin supply chain. When it came to cold chain capacity, one thing that we realized is that when it came to hospitals, almost all the hospitals had refrigerators where they were storing oxytocin. Over 90% of health centers and polyclinic also had a fridge where they were storing oxytocin. When it came to chips, about 40% of chips that were doing that reported deliveries had a fridge for storing oxytocin, it meant that there was a gap at that level where some facilities that were performing deliveries did not have the required fridges for storing oxytocin. So we estimated a gap there which needed to be filled. When it came to regulation and oxytocin labeling, on the field, we picked up a few samples of oxytocin and realized that there were different labels altogether. Some were stored in a cool, dry place. Some were to be stored between 15 to 30 degrees Celsius. And as Ghana, we know that we are a zone 4 country, and our storage and our temperatures are sometimes generally very high, especially in the northern part of the country. So as a zone 4 country, the recommendation is that oxytocin should be stored between 2 to 8 degrees Celsius. But however, not all the oxytocin was stored under that temperature. And even when it comes to the labeling, not all the oxytocin was labeled to be stored between 2 to 8 degrees Celsius. As you can see, this is a photo that we picked up in the field, and it's saying that oxytocin stored between 15 to 30 degrees Celsius. FDA was doing its best to enforce this, but these enforcements were not easy. Though they were conducting market assessments and doing inspections here and there, it was not an easy process. When it came to finance, as I've already explained earlier, one thing that we realized was that because of the UNFPA reimbursement price, the oxytocin is being by us under normal circumstances. No woman is supposed to pay the facility. But because the reimbursement price was low at the current market price, in some of the facilities that we visited, we were doing a payment because they are at the price on the market, not matching the everyday reimbursement price. So they asked the man to top up. For some of the facilities, ask the man to get their own oxytocin the market on them. You cannot guarantee the quality of the oxytocin for others, and they have.
So it sounds like Afu is having a little bit of a connection issue. I'm wondering, Megan, if you could share your screen, or Shamia, and then perhaps another member of the team can go ahead and continue with the slides, at least until Afu is ready to reconnect.
Sorry.
Yeah. Sure, I'm happy to. Let me take a
Thanks.
look.
Are we okay?
F4, are you still there, dear?
Yes, I'm here.
Okay, let's see if you can talk through this. The connection's just getting a little bit cutty-outy, and if it doesn't work, then I'll jump in. But let's see if you can.
Megan, can you hear me?
Yes, I can hear you.
So we definitely needed to do something about when it came to our reimbursement prices of oxytocin too. So we studied holistically the supply chain, and we proposed a few recommendations. And I'm happy to say that these recommendations have worked marvelously for the oxytocin supply chain. Though we continue our work on it, we continue our advocacy efforts. Claudette is here from the Ghana Health Service to tell us a few of the recommendations that as a project we have proposed to tackle holistically the supply chain. For instance, Eastern region, upon studying its temperature that they were keeping oxytocin, has gone ahead to replace some of their oxytocin storing fridges so that they can ensure that oxytocin is being stored in the right temperature. So Claudette is from the Ghana Health Service. She'll give us a few of the recommendations that the project has proposed and the progress up to date that as a country we have made. So over to you, Claudette.
Thank you very much, Efwa, for your presentation. Yeah, so as Efwa has said, the assessment that was carried out and all the work that has been put in the past has really helped out. As she said, as a Zone 4 country, it's very necessary that every oxytocin that comes into the country should have a clearly labeled temperature range of 2 to 8 degrees. So it was recommended that we should make sure that FDA ensures that all the registration or registered oxytocin have clearly labeled the oxytocin. We are pleased to say that this has been done. And then as much as possible, our national health insurance reimbursement has actually revised their prices to be able to mark up what the international prices are, so that at the end of the day, substandard oxytocin will not be purchased in the light of the fact that the reimbursement package that facilities should receive are smaller than what is the real prices on the market. Also, there was a recommendation that we should strengthen our inventory management system and cold chain processes at all levels of the supply chain, as well as the facilities that we have in country. As it is now, we have strengthened our inventory management, and we see that we are able to continuously monitor and then see what the stock levels are in regards to oxytocin in the country. Also, we are trying to fill up our cold chain gaps at health facilities for oxytocin. And as we had actually earlier shared, we have some fridges that USAID is actually considering to purchase for some number of facilities that we have in Ghana. We are also pleased to say that one major achievement that we've actually made as a country is the fact that we have included oxytocin as part of the central frameworking contracts, such that at the end of the day, the country or the regions are able to enjoy economies of scale, and also to make sure that they do not source oxytocin from just any provider or any supplier, except those accredited and those who have actually signed the contract to produce or to provide the oxytocin of higher quality. In such a way, we are sure that we do not have any substandard entering our facilities. So these are a few recommendations that came up, and then as a country, the achievement and the progress to date. Thank you very much. Thank you.
Great, thank you so much to the speakers. Any other final comments from any of the panelists before we open it up for questions and answers? We actually don't have any questions yet in the Q&A box, but I encourage our attendees to go ahead and put those questions not in the chat, but into the Q&A box that is at the bottom of your screen. If they're not, well, questions are starting to come in. Maybe I can throw a couple out there that came up in the last session, and that is, can you talk a little bit about overall awareness of temperature control and quality control for medicines in Ghana, and what you've encountered among the different stakeholders?
Okay, so I would say that we still continue the work with awareness. What we did initially is that we contacted the Director General of the Ghana Health Service to send a communique round to the RMSs, to the facilities, to tell them about oxytocin, and also to tell them to store it between 2 to 8 degrees Celsius. That's the first stage which we have done. We have also modified our end-use verification to our end-use verification is a survey which is done by the Global Health Supply Chain Project. We visit a number of facilities to be able to support them. We've modified our end-use verification to include oxytocin, a lot of things about oxytocin. So it gives us the opportunity that when we get to a certain facility, we're able to check how they are storing oxytocin, we're able to educate them. And on any forum that we get, for instance, we have presented twice at the Maternal and Child Health conference in Ghana, where a lot of stakeholders were gathered. So as a project, what we do is that we still continue to create the awareness till it gets to the last person who needs to hear that oxytocin needs to be kept cold and needs to be kept between 2 to 8 degrees Celsius. So we've tackled it from all the angles, and the work still continues.
Great, thank you, Afan. Still a little bit more time for questions. Okay, if not, another question that came up in the last session Can you talk a little bit about some of the issues around power supply, particularly in rural areas? Has this been an issue? Is it an issue with regard to having functioning generators, or have you not encountered this as much?
Claudette, I think Claudette handled a bit on that. So when she's done, I'll come and I'll add a bit.
Okay, so as it is, as a country, we have some facilities that have cold boxes, or let's say it looks like as a country, all the facilities have cold boxes as a backup. So what it is that in the event where there are power outages, that is something that is very common in our country. They quickly go ahead and then store these oxytocin into these cold boxes with the ice packs on them. But as it is, because of the assessment or the recommendations from the assessment that came up and the advocacy work that has been done, we realize that now new refrigerators that are actually being purchased are encouraged to be dual power source, as in the fact that we have those that are electrical power based, and then we have those from gas, so that in the event that there is power outage from electricity, they can just switch on to the gas. So that is some of what we are actually doing to be able to keep out those power outages that we have. Over to you, Ifa.
Yeah, it's fine. I think Claudette has already explained that.
Great. Thank you. So another question that came up in the previous session, has the government thought about using misoprostol where cold chain is not available? It is also effective and on the WHO recommendations.
Claudette?
Okay. Yeah, so misoprostol is part of our main commodity or RH commodity in the management of PPH and other related maternal issues. But as it is, we are all aware that when it comes to oxytocin, it's actually the #1 treatment that is used for PPH. So it's very important that we can't have substandard oxytocin in country. So that is how come we are doing everything possible to make sure that all oxytocin that are used for the woman is of high quality. But misoprostol is part of our standard treatment guidelines. Thank you.
Great, thank you, Claudette. We probably have time for one more question. We have until 10:10, and then we are all back to the plenary at 10:15. If not, then maybe I'll turn it back over to the panelists for some final words in turn.
Thanks, Lisa. I think the presentation and the issues around quality assurance and availability of quality assured products are, as I said in my opening remarks, essential or very important in order to ensure quality of care and in order to prevent maternal mortality, maternal morbidity. I think oxytocin is almost an easy conversation to have because of its sensitivity to heat, but these quality conversations extend across all of the products that we've been talking about since yesterday. Tranexamic acid, heat stable carbetocin, all of the tools in our toolkit, if you will, to deal with major causes of maternal mortality and morbidity, all of them still need to be quality assured. And I think getting this message across and having folks understand why it's important to invest in quality assurance and quality control is still something where we still have a lot of work to do. I think it's a hard conversation to have. I think it's a hard concept to convey, and I don't think as a community we've gotten quite there yet. So again, conversations are very important, and we have to, all of us from our different vantage points in providing quality of care, need to make sure that the products we are managing are of good quality. Over.
Thanks so much, Beth. With that, I want to thank the panelists for joining us today and for everyone attending the session. You have a few minutes here to head into back to the plenary. And please be back in the plenary by 10:15. Thanks again to everybody for joining Breakout 4.
Thank you too.
Thank you very much.
Thank you, F1, Claudette, and the entire team.
Thank you. Great
Thank
work.
you very much,
Thank
Lou.
you.
Great work,
Thank you.
Anna. All right. Thanks so much, Shimi. I guess we'll close up shop here.
Yes, Lisa, I'll do it right now.
Great. Thanks.